Severe anemia is common among children in sub-Saharan Africa. It affects up to 15% of children admitted to hospital and is a major cause of death. It's usually treated with urgent blood transfusions, but there's often more demand for blood than supply. Because of this, World Health Organization guidelines recommend conservative blood transfusion strategies. Transfusion is restricted to only children with complicated or profound severe anemia. They recommend giving blood to children with haemoglobin of less than 4 grams per decilitre or 4 to 6 grams per decilitre with complications, such as respiratory distress or impaired consciousness. A low dosage of 20 ml per kilo of whole blood or equivalent is used for transfusion. Standard formulae suggest that 30 ml per kilo would be needed to correct anemia in these children. Children admitted to hospitals in Africa with severe anemia have poor outcomes. Studies suggest that around 1 in 10 die in hospital, and another 1 in 5 die or are readmitted to hospital in the 6 months after discharge. This raises the question of whether the current transfusion guidelines are correct. They are based on expert opinion, not evidence, because no well-designed controlled studies have been done. The TRACT trial tested different transfusion strategies aimed to reduce mortality and morbidity among children with severe anemia in Uganda and Malawi. One question was how much blood to give. 3,196 children aged between 2 months and 12 years with severe anemia were randomly assigned to receive either a liberal transfusion of 30 ml per kilo or a conservative transfusion of 20 ml per kilo, as currently recommended by the WHO. The primary endpoint was mortality at 28 days. Overall, TRACT found no evidence of differences in mortality between children randomised to receive higher volume 30 ml per kilo compared to the standard 20 ml per kilo. By day 28, 3% of children in the 30 ml per kilo group had died, compared to 5% in the 20 ml per kilo group. This difference was compatible with chance. In an unexpected result, the trial found strong evidence that the effects of transfusion volume varied by whether the children had fever or not when screened. This result has important implications for treating children with severe anemia. Children without fever at the time of screening, 2/3 of those in the trial, were at half the risk of dying by day 28 if they received 30 ml per kilo rather than 20 ml per kilo. This was what the trial had hoped to find originally, that more blood than the conservative 20 ml per kilo recommended by WHO was needed to correct anemia and improve outcomes. In contrast, the 1/3 of children with fever had almost double the risk of dying by day 28 if they received 30 ml per kilo rather than 20 ml per kilo. At the moment, we don't have an explanation for this, but it was not due to the higher transfusion volume causing heart failure. These completely opposite effects are called heterogeneity. In this case, the p-value for this subgroup analysis of variation by fever was p equals 0.001, showing unusually strong evidence of heterogeneity. Other analysis of the results showed that haemoglobin increased more among children receiving 30 ml per kilo compared to 20 ml per kilo, with mean haemoglobin nearly plus 1 gram per decilitre greater at 48 hours. However, by day 28, there was no evidence of differences in haemoglobin between groups. Around 1 in every 5 to 6 children were readmitted to hospital within 180 days. There was no evidence that readmission rates differed between the two groups. Only 45 children experienced allergic reactions, and 5 experienced lung injury suspected to be as a result of the transfusion. This is just over 1% of children in the trial. There was no evidence that rates of these events differed between the two groups. The two strategies used similar numbers of blood packs overall, as children receiving 20 ml per kilo were more likely to need 1 or more extra transfusions. Health economics analysis found the cost per life year gained was $20 for giving children who did not have fever at the time of hospital admission 30 ml per kilo compared to giving them 20 ml per kilo. This was well within cost-effectiveness thresholds for Uganda and Malawi. Neither the type of donor blood nor the length that the donor blood had been stored before its use affected 28 or 180-day mortality, suggesting component preparation to make packed cells is not essential for safe transfusion practice. Providing whole blood rather than packed cells could save costs for transfusion services. Implementing a 30 ml per kilo transfusion strategy for children with severe anemia but without documented fever when they come to hospital could save a substantial number of lives in sub-Saharan Africa each year.